Good afternoon to everyone. I would like first to thank all the audience for being here, especially those that are clinicians, that maybe the first two presentations have been quite complicated and you are not really confident with this kind of knowledge about the diffuse optics. So a special thank to them, their assistance. And I hope that these presentations have been useful for you in order that you maybe can introduce some ideas in your areas or fields of work. I also would like to say that it's a pleasure to be here and also to be part of this consortium and this project. It has been really challenging and interesting and exciting for me taking part of this work, but obviously it's very different from my normal work that I'm used to do. So it's very exciting and I have learned a lot. So I hope that you enjoyed the presentation and all the work that we have already done. Beginning with the presentation, as a part of the audience is not clinician, I think that it's appropriate to begin with a brief introduction about the anatomy and the physiology of the thyroid. Afterwards, I will focus on nodular thyroid pathology, and I would explain which are the main tools that we have nowadays for the diagnosis and also the problems that we have with these tools. Torgot has explained very well how the project is, so I will go on and introduce the main results that we already have about a pilot feasibility study on healthy volunteers and also a pilot feasibility study on a small group of subjects with thyroid nodules. I would like to remark that although they are interesting data, the results are very preliminary and we have to include also more patients and introduce also more variables to analyze. To begin with, this is the thyroid. Okay, and is a gland that is located in the base of the neck below the apple's neck. It's formed by the right lobe, the isthmus, and the left lobe, and here the pyramidal lobe. And its main function is to produce, store, and also to release the thyroid hormones to the bloodstream. Has a butterfly shape. And is the main challenging for diffuse optics is the fact that it's surrounded by a lot of structures. On the one hand, we have vascular structures that may interfere in the measurements, and also in this transverse view of the neck, you can see that in the surface you have the skin and also the adipose tissue. Below you can find the muscle structures, and here you have the thyroid in the transverse view. Below the thyroid, you can see the trachea, the esophagus, and also the cervical vertebra. The main tool that we have to study the ultrasound in a morphological way is the ultrasound. And this is the image that we have of the thyroid by ultrasound in a transverse way, similar that the one before the one that we have seen in the previous slide. Here we have the skin, the adipose tissue, the muscle structures, and here we have the thyroid with the right lobe, the isthmus, the left lobe, and here the trachea, which produces a shadow in the image of the ultrasound, and here you can see the vascular structures. Each lobe is formed by a functional structure that is the follicle. And each follicle is formed by follicular cells, cubic follicular cells, that are surrounding the colloid, that is very rich in thyroglobulin, that is a marker that we use in diagnosis. And follicles are surrounded by vascular structures, arteries, and also capillaries, small capillaries that supply each follicle individually. How the thyroid works. The thyrotropin, that is an hormone that is produced by the hypophysis, is released and goes to the thyroid and stimulates the follicular cells to produce the thyroid hormones. Here, the iodine has an important role to produce this hormone, and also the sodium-potassium ATPase bond that is also engaged in this work. For endocrinologists, one of the most important work that we have to deal with is the thyroid pathology, and especially nodular thyroid pathology. The prevalence of thyroid nodules is quite high. By palpation, it really reality is low. We have a 5% of prevalence in thyroid nodules in women and 1% in men. But when we perform an ultrasound, this prevalence increases a lot. Almost 70% of ultrasound performance are associated to a thyroid nodule. And this prevalence increases in women and in elderly. And the main challenge that the endocrinologist has to face is distinguish benign from malignant lesions. We have to take into account that the prevalence of thyroid cancer is between 7 and 50% of nodules, and this prevalence changes between sex, age, and also radiation exposure or family history. And also an interesting data is that the incidence in thyroid cancer is increasing a lot. And here we have some data from United States in which you can see that in 5 years, we have almost duplicated the number of new cases. Majority of thyroid cancer are associated to cells that belong to the thyroid, and less than 5% correspond to other kind of cells such as lymphoma, metastases from other organs, or sarcoma. In relation to carcinomas, majority are papillary cell, 75%, and folliculars. These are differentiated thyroid carcinomas. Medullary and anaplastic thyroid carcinomas are associated to a poor prognosis, but fortunately are less frequent. So when we suspect a thyroid nodule, we should undergo a thyroid ultrasound and probably also a final aspiration to obtain a sample of the cells of that nodule will be required. When we have a thyroid nodule, we can have some clinical information that may help us to decide whether this nodule may be malignant. This data, for example, is the history of family history of medullary thyroid carcinoma or multiple endocrine neoplasia, or characteristics from the nodules such as rapid growth or hard consistency, or the fact that the nodule is fixed to adjacent structures. Moreover, the presence of vocal cord paralysis or regional lymphadenopathies and obviously distant metastases also make us suggest that the thyroid nodule is cancer. So the next step is to perform a ultrasound, and we can find some characteristics that we can see in the ultrasound image that can help us to suggest that this nodule is malignant. These are some of the characteristics, for example, hypoechogenicity, microcalcifications, the absence of halo around the nodule are suggestive of malignancy, for example, irregular margins and the presence of invasive growth also, and the presence of lymphadenopathies, high intranodular Doppler flow, and also a shape in the transversal view taller than white are suspicious of malignancy. Here you have some pictures of the images of these characteristics. And I would say that we can divide them into types. For example, we have hypoechogenicity that, as you can see in this picture, is the image that looks darker, the nodule looks darker in comparison with the rest of the thyroid parenchyma. This hypoechogenicity and also the intranodular hypervascularization of the nodule are typical characteristics that are associated to high sensitivity but low specificity. What does it mean? This means that when we find a nodule that do not have these characteristics, for example, is hyper or isoechogenic or has no vascularization, you can be almost sure that this nodule is benign, or you have a great idea that this nodule is benign. And the fact that a nodule presents these characteristics, such as hypogenicity and intranodular hypervascularization, suggests malignancy, but both benign and malignant nodules can have these characteristics. So doesn't help very much to distinguish between them. The other characteristics, for example, microcalcifications, the absence of peripheral halo, or the presence of regional lymphadenopathies, and this taller than white shape in the transverse view, are, instead of the previous, are low sensitive characteristics but high specificity. This means that when you find these characteristics, you are almost sure that you have a thyroid cancer in that nodule, but the probability that you find these characteristics is low. So you find characteristics that are very frequent but not specific, and others that are very specific but not very frequent. No? And when you try to join some of the characteristics in order that you find several of them in the same nodule, the problem is that you increase the specificity, you are more sure or more, you have more probability to be with a thyroid cancer, but the probability that you find them is lower. So according or taking into account these characteristics, the clinician has to decide whether to perform a fine needle aspiration in order to obtain a cell sample that the pathologist would analyze. There are different risk stratification systems that have been introduced. One of the most important is those introduced by the American Thyroid Association, whose guidelines were last published at the end of 2015. And in these guidelines, they show that they show a great risk of malignancy in which, as the risk increases, the indication of fine needle aspiration would be by a nodule of lower size. So in this case, for example, in poorly cystic nodules in which the probability of malignancy is really low, almost zero, no fine needle aspiration is required. But in those nodules in which the risk of malignancy is very high because they have the hypoechogenicity and also other characteristics that are very specific, the indication is in nodules of about 1 centimeter. Other risk stratification systems that have been introduced is thyroids. This is well known and really introduced in the radiologist and endocrinologist study of thyroid. This was first developed by Eleonora Hobarts in 2009, but I think that has been really introduced in the clinical practice afterwards. As you can see, establishes different categories, and as the category increases, the risk of cancer is higher. In general, the nodules that are associated to malignancy are classified as thyroids 4 and thyroids 5, and being thyroids 5 the most associated to malignancy, thyroid 6 implies a fine needle aspiration that is positive. So in these two cases, thyroids 4 and 5, fine needle aspiration would be indicated whatever is the size of the nodule, okay? And here you can see how you establish the classification. As you can see, the idea is showing you that it's quite complicated. In my opinion, it's not an easy classification. You have to take into account a lot of aspects, and sometimes it's quite difficult to decide which is the point or the category in which you have to classify your nodule. However, it is a very introduced classification, and the correlation with malignancy is quite good. And more recently, the European Thyroid Association introduces this other risk stratification system that is called EU-TRAS. In my opinion, is simpler. Here is very similar to ATA system, in which you introduce these basic characteristics, and as the category increases, the risk of malignancy also increases. And also, as ATA system does, as you increase in the risk category, the indication of fine needle aspiration is associated to a smaller nodule. Whatever is the classification that you have chosen to classify and decide the indication of fine needle aspiration, once it is performed, you send the sample to the pathologist, and according to the Bethesda system, the pathologist will give you 6 possible results. So here we have the 6 possible scenarios. The best scenario would be Bethesda 2, which the risk of malignancy is really low and the diagnostic category is benign. And in these cases, the usual management is clinical follow-up, an ultrasound follow-up. The worst scenario would be the classification Bethesda number 6, in which the category is malignancy, and as you can see, the risk of malignancy is almost 100%. And in these cases, the management is surgery in majority of them. The rest of cases are not as easy to decide the management. The first one is Bethesda 1, that implies non-diagnostic or unsatisfactory. The main problem is that the pathologist has no enough cells to take a decision and to consider that these cells are benign or malignant. In these cases, the management or the ideal management would be to repeat the fine needle aspiration. Sometimes you find again another Bethesda 1, and finally, in most of cases, you decided that that patient has to go on surgery. In Bethesda 3 classification, you can the result is atypia. That means that the risk is higher, the risk of malignancy is higher than the previous, but actually the pathologist cannot differentiate this atypia and is not able to say that this atypia is associated to malignancy or to other reasons. So in general, in this case, we also repeat the fine needle aspiration, but also molecular testing is an option. However, molecular testing has the problem that is expensive, and not all the centers have introduced it and have the possibility to perform this kind of test. Bethesda 4 is other of the challenge in the diagnosis of thyroid cancer, because in this situation you find, or the pathologists find, a follicular neoplasm, but with the structure of the cells, the pathologist is not able to distinguish between adenoma or carcinoma. So in these cases in which the risk of malignancy is higher, 10–40%, in general, the suggested management is the lobectomy, the surgery, because only histology is able to differentiate the structure of the cells and the pattern that the cells are positioned, and you can is the only way to differentiate between adenoma and carcinoma. Bethesda 5 is associated to a more risk of malignancy, and finally Bethesda 6. So this is the scenario that we have more or less nowadays. We have to say that ultrasound and fine needle aspiration is the best tools that we have nowadays, and they are a good approach and help us a lot in the diagnosis of thyroid cancers. However, we have some limitations in some cases. On the one hand, because of the limited sensitivity and specificity of the thyroid ultrasound that led us to the necessity of performing a fine needle aspiration. We have also taken into account that the ultrasound, as you know, is an operator-dependent procedure, so depends on the experience and the ability of the radiologist and endocrinologist that is performing this ultrasound exam. And also we have the limitations that we have commented before in relation to the fine needle aspiration. We have to take into account that between 10 and 20% of the fine needle aspirations will be diagnosed of Bethesda 1, those that are non-diagnostic. And this risk is higher depending on the characteristics of the nodule, for example, the presence of necrotic or hemorrhagic areas, the accessibility of the nodule, or how big the nodule is also can give us bad results. Between 5 and 15% of cases will be diagnosed of Bethesda 4, in which we cannot differentiate between adenoma and carcinoma. And also we have some diagnostic errors. So, for example, some cases, some false positive diagnostic errors in which you are diagnosing the lymphoma in a situation that is a thyroiditis. This is not really frequent, and also variabilities in interpretation that can produce false negative diagnostic errors. So, taking into account all these situations, and considering that all that information that diffuse optics were obtaining with the breast and characterizing the breast nodules, we began to work in diffuse optics with Turkut and their team. And actually the adventure began 10 years ago, more or less. And we decided to try to see whether we could see the thyroid by the diffuse optics and whether we could distinguish the nodule from the rest of the parenchyma. As the first data was interesting, we decided to develop this device that combines both technologies, because the previous data was obtained with the diffuse optics device with an ultrasound performed previously but not simultaneously to the diffuse optics measurements. So we combined both technologies to obtain simultaneously morphological data from the ultrasound probe and also that metabolic data from the optics probe. So the idea is to evaluate the normal thyroid, to see whether we can differentiate the thyroid tissue from the surrounding tissue. We also wanted to study the nodular pathology in order to see whether we can differentiate the thyroid nodule from the surrounding thyroid tissue, and whether we can differentiate the benign nodules from the malignant nodules. Moreover, in case these results were positive, the idea was to see whether this data can reduce finally unnecessary surgeries or reduce of the number of finite respirations. And finally, we also wanted to study the diffuse thyroid pathology. So as Turgut has said, we began with the LUCA project, and this is the consortium and all the partners that participate in this project. And Turgut has also explained very well how the device works. So I will begin with the results. We first performed a pilot feasibility study in healthy volunteers. We have already measured and analyzed 11 controls, 6 women, 5 men, with men mean age of 35 years and a mean body mass index of 22. And the most important aspect in these cases was to exclude any thyroid pathology. For that reason, we performed a blood sample test in which we checked that thyroid function and thyroid autoimmunity was negative. And we also performed an ultrasound study to check that the thyroid was morphologically normal. So we first analyzed the data from hemodynamic parameters, and we included data from total hemoglobin concentration, tissue oxygen saturation, reduced scattering coefficient, and blood flow index. And as you can see in these box plots, the main results is that there are differences between these parameters between the healthy thyroid and the muscle, suggesting us that we can differentiate the thyroid from the other structures, especially the muscle. Here we have measured the sternocleidomastoideo muscle that is surrounding the thyroid. Okay. And the next step was check whether this device was precise and which was the variability between repetitions. This has already been explained by Turgut, so I'm not going to repeat this, but the idea is that we found good results despite the challenging of having low optical signals on thyroid. And we have to take into account that the first values were not as good as expected, because we had to assume some improvements on the device, especially in software and in probe and in the protocol. And the idea is introducing and measuring 10 extra controls that also will be matched by age with patients, because as you will see, patients are older than the controls that we have already recruited. These measurements were also performed afterwards with patients, and actually the data is better than this, probably because of these improvements in the device. This is the data from the pilot feasibility study in the patients with thyroid nodules. We have already measured 31 patients, 24 women, 7 men, mean age of 52 years, and body mass index of 25, more or less. Low prevalence of pathologies, of other pathologies. In general, all of them, but 2 people presented normal thyroid function. And between these 31 patients, 15 presented benign nodule, 10 multinodular goiters, and 8 malignant nodules. And now I'm going to present the data that we have in relation to this. I have divided the results in 2 groups of patients. First one, I will show you the data in multinodular goiter. I thought that it was important to differentiate them from the nodule patients, because multinodular goiter implies that really the whole thyroid parenchyma is altered and has alteration in the structure. And when you go on surgery with these patients, the final pathological result in general is a general hyperplasia of the thyroid. So in these cases, the whole thyroid was implied in this pathology. And afterwards, we performed the analysis in people with 1 or 2 nodules, in order to see whether these nodules were differentiated from the rest of the thyroid. And finally, we performed a sub-analysis of those patients that only presented a 1 nodule in 1 lobe, in order to make individual subject level analysis and compare also with the normal thyroid lobe. So beginning with the multinodular goiter, Here you have also the same hemodynamic parameters that we have commented on before in healthy volunteers. And as you can see, in general, there's a large variability in all the parameters. But we can, as we saw in the controls and in the volunteer participants, we see differences between the thyroid parenchyma and the muscle. And in general, this also suggests us that we can differentiate the thyroid from the muscle. In the next step, that was to analyze patients with 1 or 2 nodules in relation to the same hemodynamic parameters. We can also see the large variability in all the parameters. And the general idea is that the four hemodynamic parameters can help us to distinguish between muscle and the thyroid parenchyma, and especially reduce the scattering coefficient and also blood flow index can help us to distinguish between the nodule and the free nodule lobe. The next step was to perform an analysis in order we could see if any of these variables was able to distinguish or help us to distinguish between benign and malignant nodules. And we found that two variables were significantly different between malignant and benign nodules. These variables are total hemoglobin concentration difference between the nodule and the muscle, and also the reduced scattering coefficient. The first variable was associated with lower levels in patients with malignant nodule, and the second was associated with higher values in malignant nodules. Afterwards, we built a logistic model with these two variables, and we obtained an area under the curve of 0.84. And choosing the best cutoff value, you could see that we achieved a sensitive value of 75% and a specificity of 80% and a positive predictive value of 87%. If we represent all these points in the next figure, in the next picture, you can see here that you have a line that represents the cutoff of this model. So the nodules that are above this cutoff are classified by the model as benign, and those nodules that are below this line are classified by the model as malignant. The blue spots represents benign nodules by histopathological results, and the red one represents malignant nodules. And as you can see, in general, they fit very well. However, we find two spots that are malignant that the model considered them benign, and three spots that were three nodules that were benign, and the model considered them as malignant. So probably we have to improve this model, increase more patients, and also include other variables in this model in order to improve the accuracy in the diagnosis of thyroid cancer. The next step, as I told you before, was analyzing patients that presented a single nodule. So we could compare that parenchyma, or that thyroid lobe that presented a nodule, with the thyroid lobe that was free of nodule, and trying to perform an analysis in an individual subject level. In this analysis, we found that there were no differences between this nodule-free lobe and the nodule, nor with the muscle. However, we find that the nodule depth in relation to the skin and the adipose and adipose tissue, and also the muscle, affected the measurement of the total hemoglobin, oxygen saturation, and blood flow index. And this nodule depth was also associated with gender. So, but actually the gender was the effect of nodule depth. When the effect of nodule depth was accounted for, gender didn't have any other effect on the other variables. Okay. And we also we find that there were differences between the nodule-free lobes and the thyroid of controls in blood flow index, total hemoglobin, and reduced scattering coefficient, and also in these variables to differentiate the muscle and the patients between patients and controls. So this data is suggesting us that actually that free nodule lobe is not as healthy as would be a nodule, or sorry, a lobe of a healthy participant. Considering again the hemodynamic parameters that we have searched for in the previous analysis, in the group of single nodule patients, we also saw that in general the 4 parameters were useful to distinguish between nodule and parenchyma, thyroid parenchyma, and also the reduced scattering coefficient help us to differentiate between the nodule and the free nodule lobe. When we use the same logistic model that we used before, using the 2 variables that were total hemoglobin concentration difference between nodule and lobe, and the reduced scattering coefficient, we saw that the area under the cube using this model was of 0.9. And the best cutoff value achieved a sensitivity of 100% and a specificity of 83, with a positive predictive value of 91. And as you can see here in the picture, the model fits better in this group of patients. In order to see whether how could we improve our model, we have made a sample size calculation. So according to the model that we performed by patients with 1 or 2 nodules, we had an area under the curve of 0.48. So the patients that we have already measured are enough to achieve a statistical power of 80%. However, in the single nodule patients, we would need 2 extra patients to have a statistical power of 80%. However, the idea is trying to measure 20 extra patients in order to improve our statistical power. And additionally, we want to make some future improvements. The idea is adding other biomarkers that may be analyzed, such as collagen, lipid, water, and thyroid hormones, and try to improve the multivariate ROC analysis. We will also consider the effect of gender and the superficial tissue effects and see whether we improve the accuracy of the analysis. And obviously, we will also include data from clinical and ultrasound information to improve the model. So to conclude, I would say that these results are really preliminary. I think that we can differentiate between the thyroid and the surrounding structures with the data that we already have. And there's a large variability in all the parameters, both in thyroid, in the nodule, and also in the free nodular lobe. But seems that there are 2 variables that can be useful to distinguish between benign and malignant nodules, that there are total hemoglobin concentration difference between nodule and muscle, and also the reduced scattering coefficient. And in order to improve this data, the idea is include 10 extra control subjects and 20 new patients in the next months, and also improve the analysis, including other biomarkers such as water, collagen, and lipid and thyroid hormones. Include also clinical and ultrasound information, and try to create a composite variable that can help us to distinguish between benign and malignant nodules. I would like to thank all the LUCA consortium, obviously, but especially those that are working with me closely, such as obviously Gloria and Sabina, also Mattia, that is our radiologist, Felicia and Irene, Laura Oleaga also. And also I would like to mention Ramon Gomes, Ignacio Conjet, and Josep Vidal, because they are not implied in the project, but they have had also an important role supporting me to being able to do this work. And many thanks all of you for your attention. I hope that could be interesting.